Hello people, in the last video we started off with this topic, diabetic retinopathy. So basically this is speaking about the damage to retina that happens because of hyperglycemia, chronic hyperglycemia, that is diabetes mellitus, right? So this is a leading cause of blindness, that is diabetic retinopathy is a leading cause of blindness, hence we need to know more about it. So in the last video we saw what factors cause this, right, and what factors can increase this condition. The pathogenesis we saw, basically hyperglycemia leads to microangiopathy. That means this happens because of the cell damage, the cellular damage that happens because of sorbitol accumulation, glycosylation, protein kinase C, isomers, oxidative stress, etc. Also the platelets stick to each other, this platelet adhesion, Rolex formation of the RBCs, lipid dyslipidemia, then leukostasis, fibrinolysis which increases, viscosity of the blood increases, etc. So because of all this microangiopathy, we saw that there can be breakdown of the blood retinal barrier, there can be weakened capillary walls. So all this will lead to what? Hemorrhage, edema, right? So remember guys, the breakdown of the blood retinal barrier leads to edema, hemorrhage, leakage of lipids, that is hard exudates. Weakened capillary walls leads to microaneurysms, hemorrhages again, microvascular occlusions. The occlusions occur mainly because of the increase in the thickness of the basement membrane and the viscosity of the blood has increased. So these occlusions can lead to ischemia. Then there can be AV shunts development, intraretinal microvascular abnormalities, IRMA. So we have looked at all these in the previous video. Then we saw that as the next step, what happens? Neovascularization of the retina happens. New blood vessels are formed. Here the proangiogenic factors will be VEGF, that is vasculoendothelial growth factor, platelet-derived growth factor, hepatocyte growth factor, etc. And there will be some deletion of anti-angiogenic factors so that this neovascularization can happen, and there will be a lot of deletion of those things. Okay, so this much we have already seen in the previous video, guys. So if you have not seen the previous video, it might be helpful to look at the details of some of these. So now our plan was to look at the types and details about each diabetic retinopathy. So you have non-proliferative diabetic retinopathy, then you have the proliferative diabetic retinopathy. So non-proliferative diabetic retinopathy, you see all these things, okay, edema, microaneurysms, hemorrhage, all that. But when it comes to proliferative, it becomes the next level where it has neovascularization. Diabetic maculopathy is something that is within macular area. This can happen either in non-proliferative or proliferative, but they have made it a different category here. Then you have the advanced diabetic eye disease, ADED. Okay, so let us get started with this non-proliferative diabetic retinopathy. Okay, so in this itself you have so many stages, mild. Okay, you have what and all in this? Mild, moderate, severe and very severe. So non-proliferative diabetic retinopathy. What do you mean by proliferation? Proliferation usually means growth. So basically here there is no growth of new blood vessels. So let us say this is non-proliferative diabetic retinopathy. So here what and all will be the features? So in ophthalmoscopic examination you will see microaneurysms, right? Microaneurysms, retinal hemorrhages, retinal edema, hard exudates, cotton wool spots. So none of these terms are new for you, right? Cotton wool spots you have already seen in hypertensive retinopathy. Cotton wool spots are basically because of ischemia, it will lead to infarct of the nerve. Hence there will be white fluffy superficial lesions. This can be, the misnomer is soft exudate. It is not an exudate. It is not an exudate. It is an infarct. Okay. So basically microaneurysms, we already told you, ballooning of the blood vessel, like you can see this. This is an aneurysm. This thing is an aneurysm, the balloon kind of a thing, and when it bursts, there will be hemorrhage. These are all very thin. This aneurysm's wall, they will be very so thin that definitely they can break and become a hemorrhage. Hemorrhage is blood loss, right? So what you see here, microaneurysm, this term usually you will see only in the retina. Aneurysm, to any blood vessel you can have aneurysm, but when it comes to microaneurysm, you're speaking about very small blood capillaries, arterioles, venules, etc. So this is microaneurysm. So guys, let us look at these microaneurysms more in detail. Because of loss of pericytes, okay, what will happen? There will be focal dilation, outpouching of these capillaries, especially in the macular area, earliest detectable lesions, and then elsewhere also it can happen, okay. These appear as red dots. They leak, what and all can they leak? They can leak fluid, they can leak proteins, lipids, etc. When they break, obviously they can leak even the blood. FFA, when you do FFA, that is fundus fluorescein angiography, when you will inject this dye, etc., they leak the dye also. Okay, so this is about microaneurysm. This is a photo that we found from the internet. You can see this is a fundus fluorescein angiography, FFA, of both eyes, showing leaky retinal artery. Okay, so let's move on to the next topic then, retinal hemorrhage, right? Guys, are you understanding what exactly are we looking at till? Non-proliferative diabetic retinopathy. Here, we are talking about everything before that neovascularization. Like we have finished now, microaneurysm. Next thing, it has to burst, and what will happen? Hemorrhage, right? So we are talking about hemorrhage. There are two types of hemorrhage, deep or superficial. If it is deep, it will be dot and blot hemorrhage. If it is superficial, it will be flame-shaped. So here you can see some flame-shaped hemorrhage. You can see dot blot. This one, dot blot hemorrhage. Dot blot hemorrhages are deep. Flame-shaped hemorrhages are superficial. Okay. Then, retinal edema, guys. Now we are moving on to edema. Okay, we have finished hemorrhage. Now we are going to edema. Edema will be characterized by retinal thickening and is caused by capillary leakage. So what will happen because of the capillary leakage? That will lead to retinal thickening, as simple as that. So there will be capillary leakage, and what will this lead to? Retinal thickening, right? Retinal thickening, okay. So basically in this photo you can actually see, this is a drawn one, you can see hemorrhages, right? We can see hemorrhages. What else can you see? So let us move on now, guys. We are moving on to the next thing here, hard exudates. Hard exudates means what? This also, you know, when the lipids are coming out, right? So this will be yellow, white, waxy looking patches that are arranged in clumps or in circinate pattern. These are commonly seen in macular area. Okay. So people, what are we looking at currently? We are talking about hard exudates. So they are coming out of what? Out of the capillary. So basically how these look? They look yellowish, white, waxy. Look at this. Yellowish, white, waxy looking patches. They are arranged in clumps or in circinate pattern. These you will see usually in the macular area. They are because of what? Edema, localized chronic edema. They are composed of lipoproteins, lipid-filled macrophages. Okay. So did you understand this? Hard exudates. Okay. So let's look at this now. Hard exudates. Hard exudates are what? Yellowish, white, waxy looking patches arranged in clumps or in circinate pattern. They are common in macular area. They occur due to chronic localized edema. What do they compose? They have a lipoprotein or lipid-filled macrophages. These macrophages which have lipids, right? Lastly, we'll go to cotton wool spots, guys. Cotton wool spots, you have nothing but soft exudates, they're called as, but soft exudates is it's a misnomer. Actually, it's not an exudate coming out of the capillary. It is actually because of ischemia. So micro capillary occlusion. So now this is getting occluded. So the blood cannot flow here. So this portion here gets ischemia, right? Because this is not getting any blood flow, this gets ischemia. Now because of ischemia, it becomes infarct. When this becomes infarct, it becomes white in color, this nerve. So that is called as cotton wool spot. Okay. So what are these? How do they present? Look at this diagram here again. You can see a cotton wool spot here. So small, whitish, fluffy, superficial lesions, they represent area of nerve fiber infarcts, as simple as that. So all these terms almost you already know, right? Pretty similar, these terms are very similar to the hypertensive retinopathy, right? Now, this, we are continuing, these are the photos from the textbook, guys. So diabetic retinopathy, this is mild NPDR, moderate NPDR, that is non-proliferative diabetic retinopathy, severe and very severe non-proliferative diabetic retinopathy. Guys, in this non-proliferative diabetic retinopathy, some more features are there. Those are venous abnormalities, intraretinal microvascular abnormalities, that is IRMA, and dark blot hemorrhages. Let us look at these also. What is this venous abnormalities? So wherever there is capillary non-perfusion, right, there is no blood supply, around that area, adjacent to that area, you will see venous abnormalities like beading, looping, and dilatation. Okay. Then what is intraretinal microvascular abnormalities? IRMA. This is an important term. You have already seen it in the pathogenesis. So these are nothing but the shunts, guys, AV shunts, because of, what did you see? Because of the occlusion, right? Because of occlusion in the capillary, there can be a shunt growing here, right? AV shunt. So this is artery, this arteriole venule. Because of the occlusion, there can be a AV shunt that develops. That is intraretinal microvascular abnormality. This is, but this is not a neovascularization. Neovascularization comes only in proliferative diabetic retinopathy. That's what you have to remember here. Okay. Then coming lastly to dark blot hemorrhages, represents hemorrhagic retinal infarcts. So these are hemorrhagic retinal infarcts. Hemorrhagic retinal infarct. See, this is dark blot hemorrhage. What you studied here are dot and blot hemorrhage. Slightly different terminologies here. Dark blot hemorrhages are representing retinal infarct. However, this cotton wool spots are nerve infarcts. Remember. Okay, nerve fiber infarct. So, cotton wool spots, nerve fiber infarct. Dark blot hemorrhages are retinal infarcts. So, very quickly, let us go off to this classification here and look at this mild, moderate, severe, very severe. Very simple. We will go with simple ones here. Based on all this, based on some study, they have classified this ETDRS study classification. What is this ETDRS? So this is nothing but early treatment of diabetic retinopathy study classification. Okay. So let us see what do they mean by mild. So this one is mild, right? In mild, what will be there? This color is not suiting. Let's take a better color. Okay, in the mild one. So this is mild, they are saying. So this is the right eye. You can see the optic disc here. You can see the retinal arteries, veins, etc. here. You can see the macula. You can see the fovea. So basically this is the right eye. So this is, anyways, one is left, one is right and all that. But this is the right one. You can understand that, right? So this is, they are telling this has mild NPDR. So basically at least one microaneurysm, if it is there, then it becomes mild. So can you see any mild aneurysm here? Microaneurysm. So if there is at least one microaneurysm, then it will become mild NPDR. Now let us move on to moderate. This one they are saying is moderate NPDR. Okay. In moderate NPDR, in 2 or 3 quadrants, microaneurysms, hemorrhages, intraretinal hemorrhages can be there. Early mild IRMA can be there. That is intraretinal. What is MA? Intraretinal microvascular abnormalities, right? So some early mild IRMA, hard exudates may or may not be present, and you should have these cotton wool spots. Those things may or may not be present. But definitely what needs to be there is microaneurysms, intraretinal hemorrhage in 2 or 3 quadrants. Mild IRMA can be there. Hard or the soft exudates, that means that cotton wool spots may or may not be present. Okay. Now let us move on to the third one here. That is this one. Are you able to see? So this one, C they are calling it as severe NPDR, that is non-proliferative diabetic retinopathy. This is severe. Severe means what? 4 quadrants, microaneurysms, extensive intraretinal hemorrhages. All the 4 quadrants are involved. Kind of we can see that here, right? So then 2 quadrants of venous bleeding. Venous beading 2 quadrants, 1 quadrant of IRMA change. That will become severe NPDR. So what are they saying? Any one of these 4 quadrants of microaneurysm, intraretinal hemorrhage. Okay, 4 quadrants of microaneurysm, intraretinal hemorrhage, extensive intraretinal hemorrhage, or 2 quadrants of venous beading, VEADING, venous beading. Okay, venous beading, they are saying it is nothing but the localized increase in the caliber of the vein. Then 1 quadrant, or either 4 of this or 2 quadrants of this, or 1 quadrant of IRMA. Okay. So one quadrant of IRMA changes, that will become severe. Okay, so you can kind of see it here, right? You can kind of see it here. So this is severe. But there is something called as very severe also. Now let us look at this. This one is very severe. Now in very severe again, any two of the following, here it is a 4-to-1 rule, 4-to-1 rule, even this was 4-to-1 rule. And this one is also 4-to-1, 4-to-1, well that, you know that song, right? Like that 4-to-1 rule. Now 4-to-1 rule, what is there? Let us look at this. In very severe, guys, we are looking at very severe NPDR, wake up. Now in very severe NPDR, 4 quadrants of microaneurysms, extensive intraretinal hemorrhages, same thing. 2 quadrants of venous bleeding, same thing. 1 quadrant of IRMA, same thing. Then what is different here in very severe? That means any two of the following will make it very severe. As simple as that. Okay. Now this, we are done with NPDR. We are done with NPDR, that is non-proliferative diabetic retinopathy. Now what you should know is this one can progress into PDR, that is proliferative diabetic retinopathy. When will that happen? When there is IRMAs, intraretinal hemorrhages, venous bleeding, loops, widespread capillary non-perfusion, that is CNP, capillary non-perfusion areas. All these, whenever they are more, these can lead to, this can take the non-proliferative diabetic retinopathy into a proliferative diabetic retinopathy. Now let us look at that here. So what and all are they blaming? If there are IRMAs, if there are intraretinal hemorrhages, venous bleeding, we saw that word somewhere here, venous abnormalities here in this. Then capillary non-perfusion, widespread capillary non-perfusion areas. Okay, something to do with the infarct maybe. Okay, non-perfusion areas. So basically these 4 can lead to, these are the risk factors for progression to PDR. Remember that even in non-proliferative diabetic retinopathy, you can have diabetic maculopathy, right? The changes in the macular region, these need special mention because they affect vision a lot, right? So there can be macular edema. Diabetic macular edema is DME, okay? We will cover all these in the maculopathy video, guys. So just note that here there can be neurosensory detachment. And you know that this non-proliferative can become proliferative, and this proliferative can become advanced diabetic eye disease. So ADED. So this proliferative can then become uncontrolled proliferative diabetic retinopathy. End result will be this advanced diabetic eye disease. So here the complications will be like persistent vitreous hemorrhage, hemorrhage in the vitreous, right? Persistent vitreous hemorrhage. Tractional retinal detachment can happen. This is a tractional retinal detachment can happen. Neovascular glaucoma can happen, right? So you know that diabetic retinopathy is one of the leading cause of blindness. So in this video, we have looked at the non-proliferative diabetic retinopathy. So in the next video, let us look at this proliferative diabetic retinopathy, guys. So remember, in the proliferative diabetic retinopathy, you will see neovascularization, fibrovascular epiretinal membrane formation, vitreous detachment, vitreous hemorrhage, etc. That's all, okay? So those are the 3 points for proliferative diabetic retinopathy. So in this video, almost we have covered everything that we wanted to say, right? Main things about diabetic retinopathy. See you in the next video, guys. Bye-bye.